Our topic is on paradoxical vocal fold motion and vocal fold dysfunction. First, we will discuss what the disorder is and who it affects. Paradoxical vocal fold motion disorder, also called PVFMD, is caused by abnormal movement of the vocal folds when breathing. The vocal folds close when they are supposed to open. So when you take a breath, your vocal folds are abducting and allowing air to fill your lungs. However, with PVFMD, the vocal folds adduct when breathing in, which blocks the airway. In this figure, we see figure C has vocal folds during normal inspiration. And then in figure D, we have vocal folds with PVFMD, and you can see they are adducted. PVFMD mostly affects children and young adults. It is also predominant in females. PVFMD has been known to be often misdiagnosed with asthma. The average age of diagnosis is 14.5 years in juvenile patients and 33 years in adults. There is a reported 2-to-1 female predominance, with 63.6% of reported cases being females and 36.4% being males. Moving on to the etiology of PVFMD. There is no known cause, though there are possible contributing factors. These include, but are not limited to, shouting or coughing, acid reflux, smoking, pollen, breathing in cold air, and psychological or emotional issues.
Now moving on to the assessment and treatment of paradoxical vocal fold motion disorder. Patients are often diagnosed with this disorder with use of flexible fiber optic nasopharyngeal laryngoscopy, which helps the clinician visualize the structures inside the nasal passages, including sinus openings, the larynx, and the vocal cords. Video stroboscopy is also used, which helps provide a magnified view of the larynx and simulates slow motion vibration of the vocal folds. This type of assessment reveals vocal fold adduction on inspiration and relaxation on expiration. And these two pictures show both of the assessments that I just talked about. Some other assessment tools that help support the diagnosis of this disorder include airway fluoroscopy. This tool shows us a continuous or pulsed X-ray that allows us to see motion within the airway. There is also an assessment tool called flow volume spirometry that can support the diagnosis by observing a flattening of the inspiratory limb, which could help show if there is some airway obstruction. When assessing a patient for this disorder, keep in mind that most of these people have had this problem for a while, with many other diagnoses that have not resolved this problem. It is also important to know that this disorder is not exclusionary, so this means that there could be other neurological, laryngeal, or allergenic issues present as well. The primary treatment that is seen for this disorder has to do with behavioral management rather than surgical. These treatments include voice therapy, relaxation techniques, such as performing pursed lip breathing and taking slow, deep, diaphragmatic breaths that relax the chest and throat and reduce the sensation of constriction. Adequate hydration is also an important behavioral management tool to have when diagnosed with this disorder. If you are adequately hydrated, there is decreases in laryngeal irritation from inhaled irritants, reflux, and postnasal drainage. It is also important to note that oral decongestants and cough suppressants can worsen the symptoms of this disorder by thickening secretions and ultimately drying out the vocal folds, so it would be best to stay away from those. Some other behavioral treatments that are used are respiratory retraining and trying rhythmic breathing. For respiratory retraining, you are using passive inhalation and not forcing the air in. You are focusing on slower inhalation and exhalation, and it is good for the patient to practice this several times a day. When trying out rhythmic breathing, this behavioral management technique combines breathing with movement, such as walking. There are some ways that paradoxical vocal fold motion disorder can be managed other than behavioral management. One of these is visual laryngoscopic biofeedback. This type of treatment would be performed with a skilled speech-language pathologist, but it is a treatment that isn't widely used or researched yet. The more researchers look at this type of treatment, the more they think it could provide a more direct impact for the patient as well as differential control of excessive involuntary muscle activity. Botox has also been found to be effective for some patients, but only if dystonia has been ruled out as an etiology.
Our next topic is prevention and the effects on life. There is no way to prevent PVFM, but there are ways to manage the symptoms, such as learning new techniques to speak or breathe, or medications. Medications have helped with the symptoms of PVFM, and some medications I have listed below are prednisone, which is an oral steroid, and GERD medications. And those are also known as gastroesophageal reflux disease medications. And those medications only decrease PVFM symptoms in some patients, not all patients. Examples of GERD medications are a proton pump inhibitor, histamine blockers, or over-the-counter digestive enzymes. And I've attached a picture example of those medications. The SLP has to take into account other associated factors that could be occurring in a patient before diagnosing the patient with PVFM. Some of these factors include reflux, allergies, sinusitis, asthma, or anxiety. And these factors can be associated together or one by one, and each factor varies on person to person. Not every single person will experience the same secondary characteristics. It's important for us as speech-language pathologists to be able to help fix these secondary characteristics that go along with PVFM, because it helps the client gain back control of their regular life. And all of these factors lead to more severe cases of PVFM. Some breathing techniques to help manage PVFM were also found to help cure the symptoms. To manage PVFM, clinicians will help with breathing techniques, and evidence-based therapeutic approaches are still lacking, but speech therapy, including special breathing techniques with relaxation of the throat, seems to control the attacks of dysphonia in most patients. With the use of breathing techniques in therapy, clients will feel and learn how to control their respiration to revive symptoms of PVFM. Like we learned in our voice book, respiration techniques are used to help clients relearn how to breathe correctly. With the help of an SLP, patients suffering from PVFM can learn new respiration techniques to help them get back to their daily life. Many times people are misdiagnosed with having asthma when they actually have PVFM. If misdiagnosed, other problems may occur because of the side effects from taking asthma medications. Some results would be more emergency room visits or even hospitalizations. Some people can have both asthma and PVFM, which means their asthma medications are working, but they're still having problems because nothing is being cured for the PVFM. I have attached a table that shows the differences and similarities between asthma and VCD/PVFM. They differ with development, duration, dysphonia, localization, and the drug usage used to treat the symptoms. Since there has been little research about whether or not individuals were able to maintain or increase their regular activity levels after the use of treatment, almost nothing is known about if the life of those diagnosed with PVFM has improved. In one study I found, over half of the participants noticed improvements in light voice use, sports and leisure activities, competitive sports, moderate heavy voice use, walking several blocks, daily activities around the house after treatment. Reduction or PVFM and voice symptoms after treatment. These are some of the things that patients have noticed in relation to their symptoms or how they feel about the disorder. Some patients noticed a reduction in PVFM-related anxiety or the feeling of helplessness associated with PVFM, and they feel more in control of their symptoms. They also felt more confident on how to break an attack if it occurred. Another thing most patients noticed, and the SLPs noticed, a reduction in the severity of voice problems after SLP treatment. One case study I found was on Candace Wallert. Willard was able to run her whole life competitively, but when she got to college, she could not stop coughing and had a burning in her chest while exercising. Willard was able to run 800 meters, a 800-meter dash, but once the PVFM became too much to bear, she could barely run 20 meters. She was sent to the doctor, and he diagnosed her with asthma. After using 5 asthma medications and nothing was working, she went to a pulmonologist. The pulmonologist used a test called continuous laryngoscopy, which allowed the team of doctors to see the vocal folds during exercise. The pulmonologist saw Willard's vocal folds were closed during exercise, which made it very hard for her to breathe. She was then diagnosed with vocal cord dysfunction and then treated correctly. Willard is now able to run again and back to living her normal life. This is just an example of the importance of SLP and diagnosing PVFM correctly. And here we have attached some example videos of PVFM so you can see the vocal folds in action. We think they're very helpful and you should check them out. And here are references.